This is a case wherein I will be performing a phaco emulsification in a complicated cataract. This is a one-eyed patient, and although the posterior segment just showed some choroidal thickening, the intraocular pressure is extremely low and we are suspecting a cyclitic membrane. Here's how the surgery went. Initially, I am placing my 2.8 millimeter incision, and you can see how difficult it is because of the low pressure in the globe. The left side port incision is slightly tilted due to the hypotony, perhaps, and this will definitely give me problems in the course of the surgery, as you will see. I then put in an air bubble and stain or attempt to stain the anterior part of the capsule, and express both the trypan blue as well as the air bubble with 2% HPMC. Placing some HPMC over the cornea, and then using a Sinskey hook, I am trying to separate out the pupillary membrane, and I have got most of it out. I then take a Utrata forceps and remove the pupillary membrane. This is very important to do, and here I have placed a bit of adrenaline, and I have an adequate sized pupil to perform my phaco emulsification. I then go ahead and using a bent 26 gauge needle, I perform my rhexis. All the steps are a little difficult because of the extreme hypotony. Once I have the flap with the cystotome, it's pretty easy to go ahead and make an adequate sized rhexis with the Utrata forceps. Next is the hydrodissection. I can see the nucleus moving forward. Looks like there is adequate hydrodissection. And once again under HPMC, I'm planning to chop this nucleus, and hence I've got a sharp chopper in my left hand. I remove the superficial cortex, and the iris is a little bit floppy, and because of the mistake in the construction of the side port, look what's happening at the paracentesis wound where my chopper is. The iris has prolapsed through that, but I am just going ahead. I need to get this through. In fact, that iris prolapse out there gives me some space for visualization to perform my chops adequately. I am very carefully emulsifying the fragments. I do not want to get the pupil into the phaco probe. Once I have done one, push back the iris and then place some HPMC in the hope that it doesn't prolapse again. I now rotate my nuclear fragments for easier access to the phaco probe. As you can see, I am now going to eat the whole heminucleus. I am not going to place my Sensky hook through that paracentesis for fear of the iris prolapsing again. And it's only at this time when the fragment has gone behind that I put in my Sensky hook and push the nucleus fragment towards the Phaco probe. I don't anticipate much problem with the IA because the IA tip is going to block most of the paracentesis, so I don't anticipate any iris prolapse through that. There is a pretty good red reflex, and that hopefully will herald a good visual outcome. And in fact, this patient did have a good visual outcome. I'm going ahead and cleaning the posterior capsule as well. And under HPMC, I am placing a single piece foldable lens within the bag, just making sure that I get the trailing haptic into the bag. There it is. I'm now just aspirating all the HPMC out. That's my intraocular antibiotic, and I hydrate the wounds, perform the bounce test, and since it's adequate, I conclude the surgery. Thank you.